All right, everyone. So this video is different from the other videos that you have seen so far. So there is compilation of the instruments which is used in ophthalmology, and these instruments are required in main operation theater, minor OT procedures, dark room, and some of these are itself used in examination. And I'll also be telling you the basic usage of these instruments. So starting with the first instrument, it is operating microscope. So if you want to operate a patient, any case, cataract, glaucoma, trabeculoplasty, you want to perform any intraocular procedure, you want to perform any ptosis, entropion, ectropion surgery, whatever surgery you want to perform, you have to use an instrument which magnifies the image, and eye is a very small structure, so you need magnification. For that you use operating microscope. Then there is ophthalmic cryo unit. So this is one unit whose temperature can reach up to -65°C. So cryo unit is helpful if there is any retina break. So with this you can do the retinal sealing. Yes, okay. Then there is bipolar cautery. So you can see that there are two prongs. So when there is bleeding vessel, you just touch it, you just close this two prongs, and the moment they will get in touch with each other, it leads to coagulation of the vessel. So it is also used to keep the field blood free. Then gas permeable contact lenses. So I am talking of contact lenses now, gas permeable. So the commonly used gas permeable contact lenses are GP, rigid gas permeable. It is made up of CAB, which is cellulose acetate butyrate. Yes, and there are hybrid contact lenses. Similarly, there are scleral contact lenses. Then there is electrolysis machine for trichiasis. What is trichiasis? It is misdirected eyelashes. So you need to remove the misdirected eyelashes. So you can basically go on for electrolysis, which helps in removal of the eyelashes. Pachymeter is the instrument which is useful for assessing the thickness of the cornea. The normal thickness of cornea is 500 to 600 micron. The average thickness is 540 micron. Don't confuse pachymeter with that of specular microscopy. Specular microscopy assesses the endothelium cell count. Endothelium cell count in adults is 2700 to 3000 cells per millimeter square. In newborns, it is 5000 to 7000 cells per millimeter square, and it decreases at the rate of 0.8% per year. Yes, okay. These are the glasses. Now bifocal glasses are in which you have the glass for distant vision and you have the glass component for near vision. And progressive is when there is the glass for distant vision, there is the glass for intermediate vision and glass for near vision. So that is your progressive glass. Okay, this is the basic terminology that you use for spectacles. Now the next is vitrectomy unit. Suppose you want to go on for anterior vitrectomy, or you want to perform any posterior segment procedure, you want to treat retinal detachment. In retinal detachment surgery, vitrectomy may be required. So that is to remove the vitreous humor. So vitrectomy unit. So there is cutter. So this is your vitrectomy cutter which cuts the vitreous. You cannot think of just aspirating the vitreous, because vitreous is attached to the retina, it is attached to the optic nerve head, it is attached to the macula, it is attached to the ora serrata. If you try to aspirate the vitreous, it can pull the surface of retina and can lead to more retinal breaks or retinal tears. For that you have to cut the vitreous and then aspirate it. So that is why you call it as vitrectomy cutter as well. What is this? This is your intraocular lens which is to be implanted in the eye after cataract surgery. So this is a form of anterior chamber intraocular lens. Now AC IOL, some sort of similar IOL can be implanted in the posterior chamber as well, but mostly the shape of the haptics goes in favor of AC IOL. Now these are executive bifocals. Executive bifocals is when the lower half, the entire lower half is for near vision and the upper half is for distant vision. You should not confuse it with that of the bifocals. Bifocal, not the entire lower half, but only this part is for your near vision. Yes, so that is the difference. Okay, now coming over to this. So this is your phacoemulsification machine, yes, with which you perform phacoemulsification. It works on the principle of jackhammer effect, and the frequency is 40,000 hertz. Frequency is 40,000 hertz. That means it strikes the lens at the rate of 40,000 times per second, such that it emulsifies the lens, and side by side aspiration is going on, and the lens is emulsified and simultaneously aspirated. There is also infusion which is going on. So this is your phaco probe. So side by side emulsification is happening, infusion is happening, and aspiration is also happening. Now you will say, sir, why there is necessity of infusion? If there is no infusion, just the emulsification and aspiration, there will be collapse of the anterior chamber of eyeball. There will be development of negative pressure inside the eyeball. Yes, so for that there is irrigation, there is aspiration, there is phacoemulsification which is going on. All right, so these are your gauze pieces, small peanut gauze pieces, hai na? Okay, now coming over to the different IOLs. So this is your foldable monofocal. Foldable is used in phacoemulsification. So monofocal is which corrects the distant vision. For near vision, after cataract surgery, the patient has to wear the plus glasses. Yes. Then there is rigid monofocal. Rigid monofocal is, you can use this in SICS, manual small incision cataract surgery, or extracapsular cataract extraction, which is conventional. But foldable is you use in phacoemulsification. You use this in phacoemulsification. Yes. Now the length of incision in phacoemulsification is 2.8 to 3.2 millimeter, while in extracapsular cataract extraction is 10 to 11 millimeter. But in MSICS is the kind of a better form of ECC, modification of ECC, in which length of incision is 5 to 6 millimeter. The most common variety of which the foldable lens is used is acrylic variety, acrylic material, while rigid is PMMA, polymethyl methacrylate. Now comes the toric lens. What is the purpose of toric lens? If the patient is having cylindrical error, astigmatism, so this can correct the cylindrical error. So you can see these three dots which are here and here. Yes, so the eye is marked pre-operatively that in which direction you have to put these three dots. So these three dots depict the axis where the IOL has to be dialed in such a way that these three dots should be along the axis where the patient is having a cylindrical error. Now this is your aspheric monofocal. Again, this is foldable. Aspheric is special lens. Asphericity helps in countering the most common late complication of cataract surgery, which is after cataract, which is posterior capsular opacity. Yes. Okay, now comes the multifocal lens. You can see the multiple rings. You can see the multiple rings which are there. So multifocal lens helps the patient in seeing distant objects clearly, helps the patient also in seeing the near objects clearly. If the patient is wearing multifocal lens, wearing means if the multifocal lens has been implanted into the patient's eye, so that gives the patient the distant vision as well as the near vision. But the quality of distant vision and near vision both are not absolute. They are relative. They are not the best. So I personally prefer to give monofocal IOLs. So the purpose of monofocal IOL, that the patient will have best possible distant vision. But for near vision, the patient will have to wear glasses. So with glasses, best near vision. Without glasses, best distant vision. But with this multifocal lens, without glasses, intermediate distant vision. Intermediate, matlab not the best distant vision, not the best near vision. Yes. And if the patient is having cylindrical error, means astigmatism, so you go on for toric. So just remember toric for cylindrical. It is given for cylindrical refractive error. Toric, C for cylindrical refractive error. Okay, I hope it is clear. Now coming over to this, what is this? This is your Schwartz tonometer. Schwartz tonometer is the indentation type of tonometer which helps in assessment of intraocular pressure. The normal intraocular pressure is 10 to 21 millimeter of mercury, but this Schwartz tonometer is not accurate, but the most accurate tonometer is applanation tonometer. This is your Goldman applanation tonometer. Gold for Goldman. Yes, so that is gold standard tonometer. What is this B scan USG? It is the ultrasound of eye. Can you appreciate? So this is your posterior segment. This is your posterior segment, which is vitreous, and here is the lens, and this is your optic nerve, and this is your status of retina. If you are suspicious, suppose trauma happened, the first investigation that you will go for suspicion of intraocular foreign body is your B scan. But mind you, if you are suspecting metallic foreign body, MRI is contraindicated. The investigation of choice is NCCT. Now you go for B scan ultrasound and you can actually see the foreign body, and if there is retinal detachment, you can actually see the retinal detachment here. So there are waveforms which are developed, and based on this you can assess whether there is presence of retinal detachment, whether there is presence of choroidals. So you can actually assess the posterior segment properly with the help of this ultrasound. Okay, and this is your optic nerve. All right, now this is the slit lamp biomicroscope, which is used for general ophthalmic examination as well as slit lamp biomicroscopy with the help of your 90D aspheric lens. You can even use plus 78D lens. Okay, non-contact tonometer is best for screening. It is best for screening of IOP. So because it does not touch the patient, so there is no need to sanitize it after every usage, and it is very quick. So non-contact tonometer, this is your previous year question. Pinhole occluder, if the patient's vision is improving on placement of the pinhole, that actually tells me that the patient is having refractory error. Astigmatic fan test is used to assess the astigmatic error and excess in the patient. Jackson cross cylinder is used for the refinement of astigmatism, the refinement of the excess of the cylinder and that of the error, right? So these are the tests which are used for giving cylindrical glasses. You want to have accurate excess and accurate cylindrical power. Duochrome test. So you need to understand one thing, that you know na, Vibgyor. So that actually tells me that green color has a small wavelength and red color has long wavelength. So ideally what happens is the green color is projected just in front of the retina and red color is projected just behind the retina. Normally when you will show the green light and red light together, so this green will be projected here, this will be projected here. So ideally when you ask the patient to read the alphabets, so the patient will be able to read the alphabets equally, because the more in front green color is being projected, the more behind the retina red color is projected, so that the focus of green and red color is equal. Now if the patient says that the patient is able to see the green color more clearly, that means the green color, instead of being projected in front of the retina, is being projected on the retina. That is why the patient is able to perceive green color clearly. Now if the patient is able to see green color clearly, that actually tells you that the patient is not seeing red color clearly. It must have gone far behind the retina. That actually tells you that the patient is hypermetropic. Yes, hypermetropic. How will you remember? Just remember is gap. If the patient is seeing green color clearly, you need to add plus power. Yes. Now what if the patient is seeing red color clearly? So that means ideally I told you na, green color is normally projected in front of the retina, red color is normally projected behind the retina. Now if the patient says that I am seeing, ideally both should be same, because the more anterior green is, the same posterior red is. But when the patient says that the patient is able to perceive red image better than the green, so that actually tells me that red is not actually behind the retina, red is on the retina. When red is on the retina, that means green is more anterior to the retina. That actually tells me that you need to add minus glasses to bring the red posteriorly and simultaneously green more posteriorly, so that red appears just in front of the retina and green appears just behind the retina. So this is your duochrome test. All right. Okay. Guys, this is just a revision session. In case you have further doubts, you can get back to me anytime. You know that, right? Now coming over to retinoscopy. Retinoscopy is the subjective method or objective method? It is the objective method of estimating the refractive error in the patient, because you don't ask the patient to read the Snellen's chart A, XO, HTV. You are not dependent on the subject. You assess by itself. Yes. And this is your reflecting mirror microscope. There's a bulb which is in the front and you have got a mirror and hole through which you reflect the bulb's light into the patient's eye and you look out for the movement of the red reflex. So this is again the double mirror retinoscope, but nowadays self-illuminated streak retinoscopes are present. Wait, I'm just going to show you. It is here. Wait. So this is your streak retinoscope. I'm just going to show it to you. So this is your self-illuminated streak retinoscope. Yes. So you actually rotate it along the x-axis and you do it along the y-axis, and you appreciate the red reflex which is coming from the eye. And based on that, you can actually assess. For a retinoscopic detailed video, you can visit Retinoscopy in the same channel, so you can check out the videos. I had posted that around 10-15 days back, and you will be able to understand the detailed retinoscopy and how to give the glasses and how to assess the refractive error of the patient with the help of a retinoscope. Now, test for refraction. So this is your frame and this is your refraction set, in which these red glasses are minus power glasses and black glasses are your plus power glasses, right? Okay. Now, so these are traphenes. These traphenes are used to punch cornea. Suppose this is the eyeball of the patient and this is the cornea and this is the cornea. You need to change this part of the cornea. So you take the corneal graft, you punch out this part of the cornea, the same dimensions of which there is corneal opacity in the patient, and you punch this part, you remove this part of the cornea out, such that there is a hole which is created on the cornea of the patient, and instead you implant just a moment, it has stopped working. Yes, so there's a hole which is created in the center of the cornea because you have removed the infective or opaque or defective cornea, and this is your graft. So you take the same dimensions and you put it here. For that you need to punch. So this is your trephine. I hope you have understood. Now coming over to glaucoma drainage devices. This is your bar welt, which is non-valved glaucoma drainage device, and this is again Molteno, but this is your valved glaucoma drainage device. This is your Ahmed glaucoma valve. So which is the gold standard surgery for glaucoma? It is trabeculectomy. It is gold standard. And in some cases where it is not possible to perform trabeculectomy, you go on for Ahmed glaucoma valve, you go on for bar welt, you go on for Molteno. So what you do is you take, so this is a cassette which is placed at subconjunctival level and the tube is put into the anterior chamber, and it leads to shunting of the aqueous humor from the anterior chamber into the subconjunctival space inside this reservoir, from which it is slowly released at the subconjunctival level, from where it is slowly and steadily absorbed. So the basic idea is the best management of glaucoma is medical management, and when the medical management fails, you go on for surgical management. Now you will say, sir, why best is medical? Cannot we go on for surgery directly? No, my dear friends, surgery has a very high failure rate. It has been seen that nearly 50% of the surgeries, they fail after or within 5 years, So best is you first try to control with medical management, later you can go on for surgery. If it is not controlled, medical management means you can give one drug. If the IOP is not controlled, add another one, 2, then 3, then 4. You can give the maximum tolerated drugs. I have myself put patients on 5 to 6 anti-glaucoma drugs, almost all the categories. But when it fails, then I go on for trabeculectomy or Ahmed glaucoma wall, or I can go for mix, which is minimal invasive glaucoma surgery, in which I put eye stents, in which I put express implant, but that is entirely a different story for now. Okay, now this is your stainless steel glaucoma valve. So this is your express implant. So one part of this implant, it is into the anterior chamber, while other part of this implant is in the canal or Schlemm. So basically you have bypassed the trabecular meshwork. So this is trabecular meshwork bypass stent. Now this is your corneal esthesiometer, which actually checks the sensation of cornea. And do you know in which disease the corneal sensation is decreased more commonly? It is, my dear friends, viral keratitis. It is viral keratitis. Okay, all right. Now this Worth 4 dot test is used in assessment of diplopia. This was also your NEET PG 2024 question. Diplopia, suppression, and ARC. ARC is abnormal retinal correspondence. Yes, okay. Now this Hess chart is used in paralytic squint. So the eye which is underacting, you will have a small restricted movement, while the eye which is overacting, you will have overactive movement. So this is a chart in which you plot the movement of the eye, the movement of different extraocular muscles, the lateral rectus, the medial rectus, superior rectus, inferior rectus, superior oblique, inferior oblique. So then is Maddox wing test. It helps in assessment of deviation. How much is the deviation? Assessment of deviation. Then there is Maddox rod. So Maddox rod helps in assessment of diplopia. It helps in assessment of diplopia, whether it is cross diplopia, whether it is uncrossed diplopia. Yes, Maddox rod. Then what is your this is your prism bar. So what is the purpose of prism bar? Prism bar has got two uses. One is diagnostic use. It is the best method, gold standard method of assessment of angle of deviation, number one. Second, it helps in correction of diplopia. For details, of course, you will have to go through the chapter of squint. It will clear your concepts, but in this video I am only covering the images and telling you the basic application in ophthalmology. And prism bar, I'll just write. One is gold standard for assessment of angle of deviation. Angle of deviation. And also to treat diplopia. The placement of prism bar helps in treatment of diplopia. Farnsworth D15 or Farnsworth Munsell 100 hue test. It helps in quantification of color blindness. Mind you, quantification of color blindness. Quantify color blindness. The pen is stopping it in between, and side by side I am constantly receiving the call from my hospital emergency, which is drawing my attention. So that is why Bagolini striated. There was slip of tongue in which I said it is used for correction of cylindrical error. No, that was not. I had corrected it. Hai na? Quantify colored blindness. And what is this? This is Hardy-Rand-Rittler test. It is used to assess color blindness. Then there is another card what is that card? That card is your Ishihara test. Ishihara is used for red green color blindness, while Hardy Rand Rittler is for red, green and blue color blindness. Yes, okay. Now what is reverse color blind? So can you appreciate the number which is written here? It is 74. So normal persons can read the number. If you cannot see the number, then you can be color blind. But what is reverse color blind test? The normal people cannot see the number here. But if you can see the number written here, then you can be colorblind. That is why this is your reverse colorblind test. I hope you have understood. And this is for quality assessment or qualitative assessment of color blindness, while quantity assessment is Farnsworth 100 hue test. Yes, okay. Now comes, what is this? This is your Snellen's chart. Snellen's chart is used for your distant vision. Snellen's chart can also be used for near vision, but that is a different chart. Can you tell me what is the distance of Jaggers chart which is to be placed for near vision assessment? It is 35 centimeter. This is your previous year question. For Snellen's chart, you keep it at a distance of 6 meters or 20 feet. Yes. Now you ask the patient to read the letters from top to bottom: 6 by 60, 6 by 36, 6 by 24, 6 by 18, 6 by 12, 6 by 9, 6 by 6. 6 by 6 is normal, which is 20 by 20, means 20 feet by 20 feet. You ask the patient to stand at a distance of 20 feet, you convert it into meters, it will be 6 meters. Yes. And if the patient is illiterate, not able to read, then you can show the patient the Landolt C chart. So you can ask the patient, there is a ring, where it is broken, it is on the upside, right side, left side or downside. So based on this, you can assess the vision of the patient. Or this is your E chart. You can ask where there is an E opened or opening its mouth. So whether it is on the right side, whether right side, downside, left side, upside, like this. So basically these charts are used for maybe, you know, the illiterate persons or the persons who are not much cooperative, or children like 5-6 years of age who are not able to, you know, tell the alphabets properly. Okay. Now this is Bailey and Lowy chart. This is another type of a chart, Bailey and Lowy chart. Yes. And this is also log-Marr chart, which is helpful in amblyopia, and it is also helpful for scientific assessment of the vision for research purposes. Yes, this is your case picture test used in children. Yes, so children can easily tell, okay, this is the image of apple, duck, house, star, like this. So it becomes easy. This is your optokinetic nystagmus. So there is a drum which rotates and there are black and white stripes. So when you start rotating it, and the child will fix his eye on the black stripe which is on the rotating drum. Once the black stripe will go behind, so the child will fix his eyes on another black stripe, then it will go back, then new black stripe, go back, new black stripe. So it is going to induce the horizontal nystagmus. Yes, this is your Paley-Robson chart. So you can see that the brightness of the letters are decreasing. So this is your contrast sensitivity. It is used for contrast sensitivity testing. Yes, and can you tell me which is the earliest symptom of cataract? It is not loss of vision, my dear friends, it is your loss of contrast sensitivity. Yes, okay. Now this is lid speculum. If you are performing any surgery in the eye, you need to keep the eyes open, you need to retract the lids. So lid speculum, this is universal eye speculum. Universal means the same eye speculum can be used in right eye or in left eye. Yes, so this is your eye speculum with presence of guard or with solid blades. But there can be another speculum which is a wire speculum, which is a wire speculum. So this is your wire. So this is just consisting of the wires. ठीक है जी? Okay. And this is your A scan. A scan is used for your biometry. Biometry is the technique by which you assess the intraocular lens power before going on for cataract surgery. There are two components of biometry. One is A scan, which helps in assessment of anterior posterior length or axial length of the eyeball. Second is your keratometer, which tells you about the power of the horizontal and vertical curvature of cornea. Perimetry is used for assessment of visual field. Perimetry is of three types. One is confrontational, which is bedside. You close your one eye, the patient closes your opposite eye. So you are closing your left eye, the patient closes the right eye. You bring the point of interest from non-seeing area to seeing area. The moment you are going to see the object, the patient should see the object at the same time. If you are seeing it early and the patient is seeing it late, that means the patient's visual field is compromised. But if patient is seeing early and you are seeing late, first get your eyes checked, है ना? So that is confrontational. Second is kinetic perimetry. Kinetic perimeter is the different perimeter. Goldman's perimeter is one. Lister's perimeter is the other, is another form of kinetic perimeter in which the point of interest moves from non-seeing area to seeing area. This is your Humphreys perimeter, which is your static perimeter. This is the gold standard perimeter. Static perimeter. Yes. Now this is your indirect ophthalmoscope, mostly used for assessment of peripheral retina. This is your direct ophthalmoscope, which is used for central retina. The image is vertical and erect, means virtual and erect. In direct ophthalmoscope, the image is real and inverted in indirect ophthalmoscope. The magnification is 15 times in direct ophthalmoscope. It is used for central, so it is good for assessment of the optic nerve head. So indirect ophthalmoscope, the magnification is 3 to 5x, and it is more commonly used for assessment of peripheral retinal tears. Very important. Yes. So this is your indirect and direct ophthalmoscope. This is your exophthalmometer, which assess the proptosis or exophthalmos. Do you know the exophthalmometer which is used in adults is Hertel's exophthalmometer, your previous year question. The exophthalmometer which is used in children is Ludi's exophthalmometer. These are two important questions. Schirmer tear test. Schirmer test is you check out for the aqueous deficiency. More commonly it is used for aqueous component of the tear film, your previous year question. Normal wetting should be more than equal to 15 mm. So this is Wattman number 41 blotting paper, which is placed at the junction of medial 2/3 and lateral 1/3 of the lower eyelid, and there is a wetting. This is a dye. Due to on mixing with the tears, it gets diluted and it will move forward. So here you can see that the wetting is nearly 17 millimeter in the one eye, and here it is just restricted to 6. So sphere dryness, very severe dryness is when it is less than 5. 10 to 15 is normal, 7 to 10 is mild, 5 to 7 is moderate, and less than 5 is severe or very severe. Yes. Okay. Now this is your stereo test. So this is your Titmus fly test asked in your INI CT exam. This is your circle test. There are circles. So Titmus fly test. So this is made in such a way when the patient wear this Polaroid glasses, the patient may see that the wing of the fly is slightly above the ground due to due to stereopsis ability of the eye. Okay. Now this is your circle test. Out of the group of 4 circles, one circle will appear to be slightly above the base, and there is animal test. So set of animals, one animal will be slightly above the base, above the level. So you ask the patient to touch the wing of the fly. So the patient will try to reach towards the wing of the fly. If the patient touches the image itself, so that means stereopsis is absent. If the patient is not able to touch the image, if the finger remains in the air, hovering in the air, that actually tells you that the 3-dimensional ability of the patient is there, stereopsis is there. Okay. This is your keratometer. So this is one type of keratometer, which is Bosch and Lomb keratometer, and it helps in measuring the power of the cornea, the horizontal and vertical curvature of the cornea. Placido disc, this is used for the assessment of surface of the cornea, corneal surface of the cornea. Okay. All right. Now coming over to different instruments which you generally use in main operation theater. So lens expressor hook is used if you want to pull out the lens from the capsular bag, usually done in small incision cataract surgery or extracapsular cataract extraction. Muscle strabismus hook, where you want to secure the extraocular muscle. Desmier's lid retractor, you want to retract the lid. Cat's paw lacrimal wound, when you give an incision here, you need to retract it, so you use cat paw's lacrimal wound. So this is your again self retracting lacrimal wound retractor. Then iris retractor, you want to retract the iris. This is your iris hook, flexible iris hook. If the pupil is non-dilating, pupil जो है dilate नहीं हो रहा है, let's say in a case of diabetes, I came across a recent patient who was diabetic, so I had to first put tropicamide and phenylephrine. The pupil was not dilated even after putting these drugs, and I need to operate the patient. So if the pupil is not dilated, how you are going to perform capsulorhexis, how you are going to perform phacoemulsification? So I used iris hooks. I actually retracted the iris so that the iris is completely at the periphery, and I can do capsulorhexis, I can do phacoemulsification, and after putting the lens, I remove the hooks. So that is the usage of retractors. Then there are forceps. So this is plain forceps, you want to hold any structure. Globe fixation forceps, you want to hold the eyeball so that it does not move. Then superior rectus holding forceps, for it is used in small incision cataract surgery, where you want to pass the bridal suture through the superior rectus muscle. How will you identify? It is S-shaped. It is S-shaped. Then there is cornea sclera forceps. Scleral forceps, the usage of corneal scleral forceps is that while holding the corneal graft, if you are transplanting the cornea, you can hold the graft with this, or while suturing the cornea, suturing the sclera, you can hold the cornea or sclera and suture it. That is why cornea scleral forceps. This is limbs forceps. Limbs forceps is used to hold the conjunctiva at the limbus or elsewhere, to maybe to stabilize the eye, or you are doing some surgery on one side or the other side. So basically these are the forceps which you use to hold the structures, maybe conjunctiva, cornea. With limbs forceps, you can even hold the sclera. If you have created a scleral flap, so in trabeculectomy, you can use limbs forceps to hold the sclera as well. Then iris forceps used to hold the iris. Yes, if the iris is coming out, iris is prolapsing out, so you hold it and you push it inside the eyeball. Okay. Then there is intracapsular forceps. Again, the usage of this is to hold the capsule. Intracapsular forceps. Epilation forceps, so you can see that the ends are very blunt, and suppose the patient is having trichiasis or entropion, so the eyelashes are rubbing over the cornea, so you actually pluck the eyelashes with these forceps, you epilate it, you call it as epilation. If the patient is having stye, there is hordeolum externum, there is inflammation of the base of the eyelash or hair follicle, so you do epilation, which leads to expulsion of the pus or discharge which is at the base of the hair follicle or eyelash. Then mosquito artery forceps, it is used to hold the drape, so that is the only use which is there in ophthalmology. Yes, all right. And then there is needle holder. You want to give sutures, you need to hold the needle with the help of needle holder. So there are different form of needle holders. So one is Baracquer type, another is Castrovillo type, so different sorts. Then Arugas, so there are different types. Then comes knives and handles. So can you see that the tip is pointed like this? Yes, so this is to make an incision in the cornea, incision in the cornea or sclera. So this is one knife, and this is Von Graffi knife, of course, and this is your keratome. Keratome mein you can see that the tip is diamond shaped, so it is used to give main incision during phacoemulsification, used to give clear corneal incision in phacoemulsification. It is keratome. Then there is paracentesis needle. Paracentesis is that you put the needle inside the anterior chamber and you take out the part of aqueous humor which decreases the intraocular pressure. Like the best management which you do in central retinal artery occlusion is paracentesis. You decrease the counter pressure by pulling out aqueous humor. Yes, Okay, then there is Tukes knife. Of course, it is used in sclera or corneal, cutting or procedures, entering into the sclera or entering into the cornea, the same. Then side port incision is used to pass the instruments while performing your phacoemulsification. If you have seen my video on cataract surgery, you would see me giving side port incision. That is a knife which is angled knife. The angle is usually 15 degree. You put it where you used to pass your chopper while you are phacoemulsifying, so that you can chop the nucleus into multiple pieces. Okay, then micro vitreoretinal blade, which is MVR blade in case you want to do the vitreoretinal surgery. Then there is capsulotome. Capsulotome is you want to create a capsulorhexis. So you want to create, you puncture the capsule here, then you make a flap go like this with the help of capsulotome. This pointed part is kept on the capsule and it is slowly rotated, so that there is tearing of the capsule in a way that a round hole on the capsule, which is capsulotomy, is created, hence the name, which is capsulotome. Then foreign body spud, you can see that there is a small area which is small. You put it on the cornea while doing surgery or while examining the eye in the OT. If the patient is complaining of something getting into the eye, so there is a spud, it is like a brush, you actually put it on the cornea and try to remove the foreign body which is over the cornea, maybe a sand particle, maybe a dust particle, which is constantly irritating the patient. Okay, then there is blade holder. Yes, crescent knife. Crescent is mostly used for making scleral tunnel. Now scleral tunnel is used in small incision cataract surgery. Crescent is also used in trabeculectomy. You dissect the sclera to create a scleral flap, because you want to enter into the anterior chamber and you want to shunt the aqueous humor from anterior chamber in the subconjunctival space. Okay ji, all right. Next is, I hope you are understanding. Yes, I'm not writing much, I am again repeating. The idea is I want to make this video very crisp, so that you can use this video just before sitting for your practical exam or just before you are going to appear for your entrance exam. Yes, scissors. So scissors, you can use it to cut any structures. Yes, so you can use the scissors to cut that drape sheet. And then there are different forms of scissors. One can be plain straight scissor, another can be curved scissor, like this. Then tenotomy scissor. The use of tenotomy scissor is to cut the Tenon's capsule. Yes, Tenon's capsule, you know na. So how many layers of the eye are there? Retina, then choroid, then sclera. Above sclera, no, it is not conjunctiva, my dear friends, it is Tenon's capsule. Then we have got conjunctiva, mind you. Okay, then corneal scissors to cut the cornea. Okay, then again the same corneal scissor, for which you enlarge the cornea if you need to enlarge the cornea. Then iris scissor if you want to cut the iris. Then again different types of tenotomy scissor. Vana scissor, the ends of the vana will be very long. You can use the vana scissor to cut the capsule, in case you are performing a capsulorhexis. Suppose this is the capsulorhexis, you were making a small opening and the capsule has run here. Now what you are going to do, you can use vana scissor and you can give a nick here to bring this part again here, so that the capsule does not, the tear does not get extended to the periphery. If it gets extended to the periphery, it can lead to the posterior capsular rent or posterior capsular rupture. Okay, then what is the purpose of enucleation scissors? So this is a curved scissor such that you can place it behind the eyeball and cut the optic nerve if you want to remove the eyeball. So that is the idea of your enucleation scissor. You also use the enucleation spoon, where there is a small gap which is created to hold the, or to cover the optic nerve, so that you can easily cut to secure the optic nerve. I am going to show you in a while. So this is your clamp. Here you can see that there is a flat surface. This flat surface, it is used for entropion surgeries. and then there is a chalazion clamp, this flat surface. So this flat surface is to be left on the outside, this is on the inside if you are going to give the incision from the inside, and in chalazion you give a vertical incision if you are operating the patient by everting the eyelid. If you are operating the patient from the outside, you give horizontal incision. These are two things that you should remember. Ptosis clamp, you can see that these are two pointed ends. So just remember the shape of the instrument, it will help you. The name is ptosis clamp, and of course ptosis clamp is used for performing ptosis surgery, not for chalazion, not for entropion or ectropion. The name is self-suggestive. Then there are calipers used to measure the area, like if you want to give intravitreal injection. Now you know, if you want to give intravitreal injection, the distance of the injection where you are injecting should be 2.5 mm from the limbus in case of aphakia or pseudophakia, while it should be 3 mm up to 3 mm if the patient is phakic. So how do you measure? You measure with the help of the calipers. Calipers, one is Castro-Vigo caliper. Suppose this is your eyeball. Yes, this is your eyeball, and you want to give an injection intravitreally, and this is your limbus. So you measure the distance. So it has to be 2.5 mm if the patient is aphakic or the patient is pseudophakic. Yes, and this is used to measure the distance. Yes, so there is a scale here. Just giving you an example, hai na? Okay. All right. Yes, let's move forward. Okay. Now, lens spatula. Lens spatula is used to again bring the lens out of the capsule or manipulate the entire lens. Then there is wire vectis. Wire vectis is to bring the lens outside the eyeball. Irrigating wire vectis. So on this, the lens is placed and it is pulled out side by side. There is irrigation which is going on. Then there is irrigation aspiration cannula. So this is your Simcoe's irrigation aspiration cannula. There is another modification of Simcoe's, that is Dr. Daljit Singh. Dr. Daljit Singh is a very well known ophthalmologist who belonged to Amritsar. He is no more, and he did some revolutionary inventions in ophthalmology, different instruments, different techniques. So one modification of Simcoe's is Dr. Daljit Singh cannula, used in SICS, in which you manually irrigate and aspirate the cortical matter. Iris repositor, if the iris is prolapsing out, you need to put in the iris, push inside the iris. Then in glaucoma surgery, scleral punch for performing of sclerotomy. Sclerotomy procedure is done with the help of scleral punch, which is Kelly's scleral punch. Then IOL holding forceps, if you want to put the IOL inside the eye, so you need to hold the IOL. So that is your IOL holding. Nowadays foldable IOLs is available in the preloaded pattern, and they are loaded inside the injector. So you need to inject the IOL, so it is folded. The moment it will enter into the eyeball, it will get opened. Then you dial it with the help of the IOL dialer, which is Sinski's hook, and the surgery is completed. So this is your preloaded, but preloaded is used only for foldable IOLs. This IOL holding forceps, non-foldable, because it cannot be folded. Non-foldable PMMA, if you try to fold it, it will break. But foldable is made up of special material, acrylic, silicone, hydrogel. Most common is acrylic. Kelman-McPherson forceps, again with Kelman-McPherson you can even, manipulate the structures. You can hold the conjunctiva, you can hold the part of the cornea. So this is used for holding the structures. Now this is your Sinski's hook, as I was telling you, IOL dialer. So this part, this end is kept at the optic haptic junction. So this is your IOL, this is your center part is optic, this is your haptic. You place it here and you dial it. So it is dialed inside the capsular bag. This is your hydrodissection or hydrodelineation cannula. When you perform capsulorhexis, you place this cannula underneath the rim of the anterior capsule and the lens. You inject fluid, and the fluid will pass through the capsule and the lens. It is going to generate the positive pressure, and it is going to push the lens in the anterior chamber due to positive pressure which will be generated between the posterior part of the lens and posterior capsule. So this is used in your phaco, it is used in your SICS, small incision cataract surgery. Now you know the most common late complication of cataract surgery is after cataract or posterior capsular opacity. There are some equatorial epithelial cells which comes to lie between the optic and the posterior capsule. Yes, now what happens is, if you will not polish the posterior capsule, some cells will automatically be left at the posterior capsule which will start to proliferate where between the optic and the posterior capsule, and they will cause opacity. So you need to polish the posterior capsule after taking out the crystalline lens before putting in the intraocular lens. So that is your capsule polisher. Yes, so these are different capsule polishers. Now coming over to the last line of the instruments. Okay, lacrimal sac surgery. So this is your nettleship punctum dilator. You need to dilate the punctum if the patient is complaining of watering and you realize that the punctum is blocked. Then this is your Bowman's lacrimal probes. These are used in where? Congenital nasolacrimal duct obstruction. Yes, okay. And what is the most common cause of congenital nasolacrimal duct obstruction? Imperforate valve of Hessner, है ना? So you go for Krigler's massage. If it is not cured with Krigler's massage along with antibiotic which is strobramycin for 3 months, you go on for syringing for another 3 months. If it is not cured, you go on for Bowman probing. Yes, that is the sequence. This is also your previous year question. Then you go on for bone punch. Bone punch is important. Lacrimal cannula, again lacrimal cannula, I told you it is used for syringing. You put the cannula inside the punctum and you try to push the fluid. Sometimes the force of the fluid can tear open the imperforate valve of Hessner. Bone punch, you want to perform any DCR, dacrocystorhinostomy, you need to remove the bone, है ना? So for that you need bone punch. There is bone chisel, there is bone hammer. So it is used for DCR surgeries, dacrocystorhinostomy. Okay, then lacrimal sac dissector and curate. Okay, then Calazion scoop. You can see that it looks like an ice cream scoop. And Calazion clamp, I have already told you the flat end is to be kept outside and the ringed part is to be kept inside, and you need to give vertical incision. There is coming out of lipogranulomatous inflammation and you need to scoop the lipogranulomatous inflammatory contents out. Yes, so that is Calazion scoop. Then there is lid spatula. And this is your optic nerve guide. I was telling you na, to secure the optic nerve. This is your what? This is your enucleation spoon. Enucleation spoon. And this is your evisceration spatula. But if it is looking like a scoop, then you can call it as evisceration curate. So this is very commonly put in your university prof practical examination. This can also be asked in the image based format in your PG entrance exam. Then foreign body eye magnet. If you are suspicious of any intraocular foreign body which is metallic, you can put it and you can just because there is a magnet which is attached, so the foreign body will get stuck onto this part and you can pull it out. All right, so that was my attempt to make you aware of the important images and instruments which are used in ophthalmology. For any doubts, you can always get back to me on WhatsApp. This is my contact number. You can follow me on Telegram, which is Ophthalmology by Dr. Manish Chhabra, and you can follow me on Instagram, which is EYE I means I underscore Manish. Yes, you can follow me on Instagram and let me know how you like the video. Any doubts, any queries, you are most welcome to ask me, and I wish you all the best wishes.